Welcome to On the X. My guest today is the Honorable Doug Collins, Secretary of Veterans Affairs. Secretary Collins spent more than a decade as a pastor before joining the U.S. Navy as a chaplain, later transitioning to the Air Force Reserve after 9/11 and deployed to Iraq in 2008 and 2009. He went on to represent Georgia's 9th Congressional District in the U.S. House from 2013 to 2021, serving in key roles including Vice Chair of the House Republican Conference and Ranking Member of the Judiciary Committee. Now, as Secretary of Veterans Affairs, he's focused on improving access to health care, reducing bureaucratic barriers, and ensuring that every veteran receives the care and respect they've earned. So here we go with Secretary Doug Collins on the X. We pushed out an email to our, call it 200,000 or so email subscribers saying you were going to be on the podcast and asked for some questions too, which is great. We want to make sure that when we have someone like you, I think it's good to kind of get some feedback about what's on people's minds. So some of the stuff I've got here is from them, some is kind of from us, so to speak, but we'll just kind of go through it and keep it organic too. I like to make sure I never want this to be just, okay, next question kind of thing. So, but let's just start with what are your current top priorities at the VA? Like what's top of mind for you right now in terms of what you are working on?
Well, that's easy. I think it's refocusing a very bureaucratic organization into one that has one singular focus, and that's taking care of veterans, whether that be in the hospitals, in our clinicals, or in our disability side, or our benefit side, or in our cemeteries. Whatever it is that we're going to be focused on doing the very best we can for veterans, that they get the benefits that they've earned. And I think that takes a large focus away from an organizational mindset, a structural mindset, a know first mindset, and we're putting it back into the focus of, if we only exist for one clientele, which is a veteran, then everything we should do should be focused on taking care and servicing that veteran. And
you're a veteran yourself, correct?
Still in.
You're still in. I read that. I want to make sure that's correct. So you're a colonel, correct? Yeah. Right, in the Air Force?
Mm-hmm.
Okay. So prior to coming this role for you, what was your perception of the VA? Like, what was your experience with it, your interaction, and just your overall kind of mindset? Did you have any sort of insider information, so to speak, or was it purely just, okay, I'm a veteran and I deal with this organization as needed?
No, I was a member of Congress. I dealt with it pretty intimately for 8 years.
Yeah.
Okay. In fact, was there for going back to the Choice Act, to the original Choice Act. They gave way to eventually to the Mission Act and moving forward, especially in taking the community care aspects with VHA and how we deal with our medical and community care side of the house, but also dealing in benefits and the slowness of benefits and the slowness of getting disability claims processed, and then all this stuff that frankly that we'd heard of for years and watched the department grow in size and scope and people, but yet not seeing the real benefit at the end of the day for the veteran that we're supposed to be serving. So I came into it with fairly good knowledge of having to help veterans deal with it. But always still surprised that once you get inside the organization, you start seeing really at times how positively focused it is, but also at times how inwardly focused it had become in certain areas. It was, that's always a little bit of a surprise, but having the knowledge of what it can be and also looking out to what the hindrances are I think helped a lot.
And what were those? What were the biggest things for you when you came in, day one, week one, month one, where it was like, okay, that's something that we really need to take a look at in terms of efficiency, bureaucracy, whatever you want to call it?
Yeah, I think it's what we just talked about. I think it's a focus. And I think, if you're focused on the organization, and look, we got a lot of great employees here. We got a lot of folks who do the best, in the world. I mean, there are things that the VA, our hospitals do that are better than anybody else in the country, ranging from polytrauma to prosthetics to, certain toxic exposure diseases, all these kind of things that we do better than anybody in the world, really. And then we also take care of a lot of people in just their regular health care. So it's a lot of what we have going on that are really good. But yet, again, what I found as I was getting briefings was it was more about, is this in the organizational favor, or is this in the veterans' favor? And I can't emphasize this enough, because if you're focused on saying no because, well, we just don't do it that way, or how many times I've ever heard it, well, sir, that's just not the way we do it. And when I ask the question why, and you can't give me a good answer, or you give me an answer that says, well, it's because statute says we have to, and then when I ask you for the statute, you can't deliver the statute because you're basically lying. It's about policy and procedures, which we can change anytime we want to. That's when I began to feel, notice that, this was going to have to be a change of culture and mindset as much as it was what we end up doing. What we end up doing, at the end is pretty good. The problem was we were allowing backlogs, we were allowing delays, we were allowing no in many ways to become our first answer and not the last answer. So for me, it was just more of a situation of internal alignment to what we're supposed to be doing, and that's taking care of veterans.
You talk about kind of the mindset there, but what about the actual, systems or logistics in place? Because you talked about backlogs there, and that's one of the comments we got back was kind of like, wait times, backlogs, that kind of thing. So systematically, are there streamlining efforts that are going on to improve those things, and what are those?
Yeah, that we really have. I mean, look, there's some great successes here. When I came in, there was in that backlog of disability benefits, that first initial claims, over 125 days within the VA was considered backlog. I think it probably should have been a lot less, but let's just say that was the standard at 125 days. We had over 260,000 plus claims that were over 125 days. Just in the last 6 months, 7 months, we have lowered that to under 115,000, almost to 113,000. I mean, that's cutting off, 160,000 of these down to a level in which we're dropping right now. Just to let you know, that's a 5-year low in where those claims were. But also you have to understand we also had the PACT Act, which also increased our claims. So, I mean, we've been able to overcome this. Nothing the previous administration, they came in at one level, went up. They never went down. We've came in and went straight to the point so the veterans get a decision quicker as they go through the system. Also in the terms of VHA, we increased a lot of people and a lot of money, but yet our, as a measuring stick that we use, wait times were not where they needed to be. They were going the wrong direction. And a lot, we were not using community care as we should. And I think those are the kind of things that I was seeing, that the structural issues that we've now taken on schedule, and we've taken on best medical interest for veterans to go into the community. We've allowed more flexibility in our scheduling of extra hours. We have over 1 million plus hours of extra appointment times that have been added just in the last few months on weekends and nights so that more veterans can get seen. Again, how do you get to that? You get to it from a perspective of saying that the veteran is the main reason we're here, and what fits the veteran is what we're going to be a part of. So, really, there's a lot of things going on, and we're not finished yet. We're still looking at some reorganization plans that's going to focus our hospitals and our healthcare alignment into a more centralized way to think that we can get answers quicker. VBA, which is our benefit side, is using automation to help process claims quicker. We're trying to get with DOD to let them get the medical records quicker after transition. There's a lot of structural change that we're going through right now that is all designed to help us out. But I do want to make one comment here, and we mention this a lot when it comes to, and probably questions that you got. I had to wait 2 weeks to see my doctor, or I had to wait. Okay, guys, one veteran to another. I love you, but okay, you got to get over this a little bit. All right. And I don't mean this in a bad way. Hear me what I'm going to say. So don't take this out of context. Rewind it back if you need to. I'm not saying, you got to get over it. What I'm saying is that we are a healthcare system. We're just like every other healthcare system in the country, except we only take care of veterans. Okay. But we have 170 hospitals, 1,200 clinics. So, I'm one who doesn't use the VA. I'm just not in that position in my life yet. I've never had, and I'm not going to while I'm sitting in this chair. But my doctors cancel appointments on me all the time. I get settled one that I'd schedule 3 months in advance. I'll get a call and say, hey, the doctor's going to be out of town. He's got to reschedule an appointment. That happens. The time issue came into play with VA when we went through the scandal, the wait time scandal, on the waiting list scandal, if you remember, about 12 years ago in the Phoenix, Augusta, and some areas where they weren't getting colonoscopies, where people were dying. And so Congress, and I was in Congress at the time, you had to come up with some way to say, okay, VA, are you doing what you said you were doing, or can we get them into the community to get the care? The only real way to do that was what we call wait times. That if you have if it takes 2 weeks or 20 days, then we can send you to the community. That is not a quality check. That is a make you do your job check. It's almost like, when you tell your kids you got to clean your room before you get to go out, well, you got to go measure, make sure they get the room clean, you get the check mark, you go outside. Quality and time are two different things. And so what I want to do is we're going to increase our quality so that what you're getting when you come into the system is good, but we're also opening up, as I said, more hours in availability, more times that you can get in the community so that those, quote, wait times come down. Any other hospital you go to, if you are interviewing a hospital administrator of any size, big companies across the country who own hospitals and hospital systems, even down to your local public and private hospitals. If you went in and asked them what were their average wait times, they would look at you and say, I don't know what you're talking about, because they don't measure it like that. Only we measure it like that. And members of Congress, many friends of mine, they want to use that and say, well, my guy couldn't get in for a certain amount of time, so y'all must be doing bad. No. We may have doctor shortages. We may have people who are out sick. We may have those kind of things. Same thing as you would have in the others. So we're making improvements, but also we still suffer into the same areas of healthcare that every other healthcare society does as well.
Sure. Yeah. I mean, I think thinking that everything's going to be perfect and you're going to get stuff instantaneously is just a ridiculous ideal for anybody to get to.
But it's okay to think we should. It's okay to have a standard. It is this, the gold standard, that everything's 100%, just like you said. What we're trying to work toward is making sure that everybody understands that number one is quality for what we're wanting to do. Number two is making sure that you get into our hospitals, we hire the right people, or you get to the community where you need to go.
Right. Speak to the point there. You kind of brought it up a little bit, but actually somebody asked it, the standard locally across the board, right? Like, so there's some, I think, perception of, or even experience of different standards or levels of care depending on where you go in the country, right? So how do you try to level that out and make sure it's standard across the board? Because that's a tough challenge to deal with.
No, great question. Well, I say I agree with you. It's tough, but in a way, it's really not. And let me tell you how I've addressed it. Look, the same. And maybe I use a military analogy. I mean, I know Army units that are in one base that go to another base, and there's slightly different standards. The captain and the colonel may have a little bit different quirk about, their timing. So you had a little bit of difference. But the basic core understanding is, we're a rifle company, we're a squadron, whatever, you're going to do basically the same things. What we had in the VA was this idea, and maybe you've heard this, that once you've been to one VA, you've been to them all. What a load of crap. It just is. I mean, we've been to one VA up until now, you've been to one VA. And for some reason, we got it into, and this goes back maybe to your first question, what did I find surprising? I found it surprising that we have hospitals acting as if like they're startups, that they have to operate by themselves in this sort of vacuum instead of being part of the largest healthcare system in basically the world and taking advantage of all that resources has to offer. So we've changed that mindset to now to where, look, if you're a VAMC director in Atlanta, you can get help from the VAMC director in Salt Lake. And if you're doing stuff in Salt Lake, guess what? You're going to do it in Atlanta. I had a veteran tell me one time he had moved from Salt Lake where he was getting treatment. He was amputee. He was getting treatment in Salt Lake, goes to, I believe it's one of our East Coast facilities, transferred his stuff, got in, told the PAC doctor what was going on, and was told that the treatment he was getting in Salt Lake, they didn't do in the VA. And I said, whoa, this is stupid. So that's become one of my favorite lines in the whole deal, in my whole dealings with our hospitals and all of our organization, is I tell our doctors and our nurses and I tell our folks in disability, what are you doing on an everyday basis that's just stupid? And why are we doing it? Because we've always done it that way before. Well, it's time to change that, and I've gave them freedom to change it. But that's really where you get into this issue is, you do get difference of care. We're making national standards. We're making, here's what you're going to get. Here's how we can do it, and always pushing to get better. But it's a big issue. You'd think it'd be easy, but I was amazed at the siloing of what had happened. And some of it was because of central office, what we call VACO, which is central office up here in Washington, D.C. Everybody here thought that they were the front line of VA care. I mean, our management, senior management, visiting directors, they all thought that they were the front line. I've changed that also concept as well. Hospitals and clinics are the tip of the spear. They're our front line. Everybody else is support. So get over yourself wherever you're at in the line of command. If you're not helping a patient, if you're not directly in that ER, that OR, those hospitals, you're supporting those who are. And that's our mindset difference.
Is there, just kind of in your opinion, as you look to kind of the future of the VA, are there things that you think the VA, so I'll just take the example of the Navy SEAL Foundation. Like we're constantly looking at our community and the programs we provide and going, are we providing the most relevant things to the community? And there's things that are sort of core to what we do where it'll probably never go away or close to never go away. But there's other things we kind of like bring on. It's like, we don't really need that anymore. We sunset that. Do you look at the VA the same way and think there are certain things that it should be doing that it isn't? There's things that you are doing that it shouldn't, or things that need to evolve, like kind of in between there?
Yeah, I think yes. And I'll be funnier. Yes. But I have to be careful of this because you get all of a sudden people are going to say, well, you're going to disinvolve, you're privatizing the VA and all this other bull crap that I hear from the Capitol Hill and from some VSO groups and others. You're privatizing the VA. No, we're not. Let me just set that to rest. They're not privatizing the VA. But we also have to look at what we do and how we do it in relation to our community care assets that are around. I'll use an example. We have some of our facilities that sit right in what we call medical row in some of our largest cities. We had one of our VA hospitals that sits right across the street, literally from a world-class cancer center. And this hospital was complaining that they were having trouble retaining oncologists. And I thought to myself, okay, number one, they can pay more across the street. Number one. Number two, they're a world-class oncology center. And you're thinking we have to build up an oncology practice in our facility right across the street? No, you send them across the street for community care and get that community care there and partner with the folks that's in the community. So those are the kind of things I think that I see us going more and more forward on as we go. We've also got to think in terms of the GWAT generation, which is my generation and many others. What are the needs going forward? Okay, because this is going to be a little bit of a cycle in which we get into some of the toxic exposure. We get into those who came back with partial limbs, amputees and stuff that we can't determine what that looks. We know what it looks like at 45. We don't know what it looks like at 65.
Right.
And I think that's going to be something we've got to look ahead to as we go forward. And many of what we have right now, we're dealing with polytrauma with many folks who came out of especially Afghanistan, Iraq, and others, that as you go, it's going to be, more and more difficult how we adapt with them as they grow older and other situations come up in this process.
So to that point, how do we get the VA, or how does the VA, I would say my experience with the VA overall has been positive in multiple ways, right? In terms of healthcare, and this is not just because you're sitting across from me, but just in general, in terms of healthcare, in terms of education benefits, and all of that kind of stuff. The thing that I would say I experience sometimes is kind of getting on the cutting edge of medical treatments, care, newer things, right? Sometimes, certainly when I go into my local VA clinic, it feels like we're sort of 10 years ago in terms of that kind of stuff. So to your point about toxic exposure, like trying to get that out of those kinds of things, how do we kind of do that? Like accelerate without being reckless, the kind of types of treatments that could be used by the VA.
Well, help me understand the question a little bit. And I like, just for us to talk here for a second, because I understand what you're saying. What, and I'm asking the question. So this is what I'm asking back on my podcast now. What do you think? What do you think you're missing at the clinic that maybe say you could go across the street and get somewhere else? Is there something, or is it just the perception because our facilities are 60 years old in most of our hospitals?
I know what you're saying there. Yeah, I mean, some of it is that. Some of it is kind of the facility. Sometimes it's just kind of old.
Our average age of hospitals, VAMCs, are over 60 plus years old.
Wow.
No private or public has. I mean, an old private or public hospital is 25, 30. Old.
Yep.
Old. I mean, we're great grandpas to these folks. Okay. And I've got facilities that were designed in the 40s and 50s that are still designed in that way. You can see it in the hallways, you can see it in the rooms. I mean, we've done some construction over the years, but it's some of it's perception. I go off the philosophy that perception is reality, and I have to live with it, whether I agree with it or not. Perception is reality. But let's get back to outside the aesthetics of the hospital setting. We're doing some of the most cutting edge. The VA is responsible for so much clinical trials and stuff on everything that affect people outside the VA. We're doing, have been doing it for years. We're one of the largest clinical research medical groups in the world, ranging from toxic exposure, polytrauma, psychedelics, which I'm sure we'll get into here in just a little bit.
I definitely want to talk about it. Yep.
Yeah, which we'll get into in just a few minutes, but also, with prosthetics, how we deal with, all these other issues. And then we even getting into prostate cancer, heart disease, these kind of things. We're doing all that. Did you realize that 80% of all baby docs in the country do at least a tour through the VA in their training?
I did not.
80% of all baby docs in this country do at least part of their training in a VA facility.
Okay.
And so we're getting a lot of new stuff in. A lot of things that are working, that we're moving forward. We're moving into robotics. Some of it was cost. I'll be frank with you. I mean, the Mayos, the Cleveland Clinics of the world, they can afford, the new multi-million-dollar X machine. Some of it's not been budgeted well, but we're now getting into all of the stuff that you see everywhere else. Robotics. I was just down in Houston a few months ago and got to work with one of these robotic surgery arms, which were, it blew me away. I just used 2 fingers to control this thing, and it looked on the screen, it looked like I was picking up a beach ball. And then when they showed me what I was actually picking up, it was less than like 3 centimeters apart of these little balls that we were moving between places. That's the kind of stuff that we're doing now. So we're moving forward. I think a lot of it's perception, and a lot of it has always been, and this is what I'm fighting. This is your dad or granddad's VA. This is the old VA. Nobody else wanted them. That's where you go. And yet people, when they get in, they find out their care is pretty good. They understand it. But can we always do better? Sure. I mean, that's a given in any organization. The minute we think we've got it under control is the minute we're going backwards.
Right. Yeah, I would say what I'm talking about, it isn't even necessarily a VA versus whatever you want to call it, like the regular medical system. It is that my experience as a veteran and someone who dealt with chronic illness, still deals with it on some level, is you end up going outside the whole system sometimes, because it's just not it's not covered by insurance, and it's just hyperbaric oxygen, something like that,
which we're working on, which we're actually expanding processes in.
Really?
Yeah.
Cool. Okay.
And we're also doing it. We're doing that in psychedelics. We're doing it in magnet reconnaissance stuff.
Right.
We're doing. I mean, we've got all of this going on. It's going on all over our system right now. It's just a matter of again, like everywhere else, spinning it up in the way that we get the clinicians on board, we get the proper people. Let's just go ahead and jump into psychedelics.
Let's do it. Yeah, no. Yeah, we're dancing around it. Let's go for it.
So look, we're doing 42 clinical trials in psychedelics. I mean, all the time I hear these people say the VA doesn't do psychedelics. Yeah, we do 42. We got more than anybody else. And then we're working on and partnering with others, John Hopkins and many others on this. The problem is we're seeing good results, but it's still at a scale in which, if let's just say I used MDMA. If you tried that right now and we just said, okay, everybody in the country gets to use MDMA, we in the VA and the private sector cannot keep up with that demand. We don't have the trained clinicians to do that. We're building it as quickly as we can in places like the Bronx and other places that we do this, up in Boston and others. And we're building the teams, because it really takes a minimum of 2 doctors and clinicians to actually do every treatment, which can take 6 to 8 hours. So they can't be. Right. It's not like you can do 5 after another. You can't give somebody a treatment of MDMA and say, hey, go home and tell us what you felt like. You can't do that. We're also doing ketamine. We're also doing psilocybin. We're also doing LSD. We've done everything in this process. I will hit the one that many SEALs, many of our special operator communities are getting into. I get it. I love you, but I can't do anything with Ibogaine. It's illegal. Okay. We cannot do it in the United States until something is made to where we can actually begin to look at it from a clinical standpoint here. People are going across the border to get it. I get it. And I get it that they're having some very good success. I'm happy. Once we can get clearance, then I'm sure we will do testing within the VA to see if we can open that up even further as we go. But just right now, you just have to understand that that's just not an available treatment in the U.S. in really any category.
I want to pause for a moment and acknowledge a brand that's doing something you don't see very often anymore. GHOSTBED didn't just sponsor an episode. They stepped up to support the entire IRONCLAD network, and that matters. GHOSTBED is built by people who care deeply about quality. It's a product-first company led by Mark Warner, who still shows up every day obsessed with doing things the right way. Their mattresses are all made in America, engineered with advanced cooling technology, breathable materials, and zero shortcuts. They have 3 different collections to choose from, and they've built an online sleep quiz, so you can dial in exactly what works for your body. And behind it all is a real in-house team of sleep experts, never outsourced. Right now, we have an exclusive offer for our listeners that beats any other discount out there. Go to ghostbed.com/onthex and use code ONTHEX for an extra 15% off site-wide. When you support them, you're not just buying a mattress. You're supporting the kind of companies that keep independent, high-stakes storytelling alive.
Aren't those, at the federal level though, aren't those other ones illegal except for ketamine? Isn't psilocybin still illegal?
We have the ability through the FDA for clinical trials. They've been approved for trials. Yes.
Okay.
Yeah.
So how do you see that progressing? I mean, look, that's great. And I think a lot of what you're talking about here is good messaging to hear, because even the thing you were talking about HBOT and TMS, right, to hear that there's efforts in the VA to get those things approved is fantastic. And I think that message doesn't often get down to us sometimes, so I think that's
why
really
I'm here.
Good. I know. And I appreciate you taking the time to do it. So on the psychedelic front, how do you see that actually going? Like when, you know what I mean? Like getting into there's clinical trials. When does that actually translate into care in your estimation? How long does something like that actually take?
Well, in some ways it's already translating into care. It's just not on what we'll say global scale. All right. That's our concern. And how we do that is just going, I hate to say it, but a lot of it is not just VA, but it's also, health systems wide, maybe is a better way to put this. And is there the proper, it's the only way I know to put this, is there enough financial return for hospitals, clinics, and all to do this and get the return that they need? Now, I'm going to take it a step further, and this is where I may differ than some of the folks in this. I believe that the psilocybin, MDMA, all the psychedelics should lead to a resolution, not necessarily a cure. I'm being very careful here, that would get you off of other meds. Okay. Because right now the concern is, and this is probably way deeper than most of you want to dig. There are many of the trials that are still doing the trials with the psychedelic, but also still have you on, for lack of a better term, antidepressants or others. Okay, then my question is it really a combination that got you better and that you have to stay on one forever? Or can we get you off of it? I mean, this pharmaceutical nature that we believe that a pill solves everything, we've got to get away from, in my humble opinion, because we're just not working here. So that's my goal. And I've asked point blank researchers and said, why are you doing this? And some of it, they don't take them off because it's a insurance, it's a liability risk.
Yeah.
That if they go off of it, then if something happens bad, then how do we go? So again, part of this is a cost. Part of this is a, willingness for, hospitals to take this on. The clinicals are always something that you're looking for the return on investment, the return on, but not only return on investment from a financial standpoint, but also for the person being treated as well. So I see it going forward. It's not going to be as fast as everybody wants it. And I'll be honest with you, you don't want it at this second, at least where we're at right now. You don't want it just to be opened up in a way that we're not equipped for, because then it could actually set us back if something was to go wrong and say with a system or trials that were not properly staffed or however you want to put it. And I'm not saying that that would happen, but I'm just saying this is what you could get into, because everybody wants to be whole. Everybody wants to be cured. Everybody wants to get back to where they were. And that's a very valid statement, but we've also got to be careful in how we do this. And again, we're leading the way in this. Aside from research hospitals, most of your everyday hospitals are not dabbling in this.
It's great to hear. And I agree with everything that you said in there too, about like getting people off of medications should be the goal, in my estimation, is to do that kind of stuff. So actually getting out ahead of that too, is there stuff, I mean, it's hard, but because with the VA, you're almost always, I think, dealing with people that have some kind of issue because of their military experience. But are there other ways that you see the VA getting ahead of things like preventative care type of thing to that point? So it's like, we don't even have to do this. We don't even have to do the treatment because we're already making people healthier to begin with.
Well, let me, you gave me something to bring up now. I call it my fraternal twin. And my fraternal twin is my brother in the cabinet, Pete Hegseth, as the Secretary of War. I've got to have a DOD health system and a DOD work that is already helping me before they get to me. Okay. Yep. And I saw us fraternal twins because we take care of the exact same people, just at different times in their life. Okay. Yep. From coming in to going home, so to speak. All right. The transition out is our big area of concern right now. Making sure that those who transition out have the ability, those who've earned their benefits through the VA, even if they go get a private sector job, making sure that we have them dialed in to go ahead and get treatment, to go ahead and to get their regular physicals. Naval SEAL Foundation, y'all are great folks and helping a lot of people. But, the minute you step out and, usually we had to go on our birthday, you go get your physical, go get your stuff, go get your blood drawn. Well, once they step out of the military, if they don't get back in that process, then they could work to this mindset of, I'm never going to a doctor. I'm not sick. I don't need to go to a doctor. Okay. That's just bull crap. Okay. Especially with our special operators, especially with our military folks. Your stress level has been higher. Your issues with stress on your body has been higher. Some have been injured. All of this is fact that the general population doesn't have those factors, but yet we encourage, regular physicals, regular blood work, regular things that help them out. Because if you're taking care of it at age 35, and you're making sure that you're eating right, you're staying healthy, and doing those things, you're going to turn out much better at 55. You're also going to be more physically and mentally fit later as well. So this is really where we've got to be. And so we're pushing heavily on preventive. I'll be honest, I'm not happy with how we've done preventive medicine. I think we could do it better in the VA, and working on nutrition, working on the getting our cycle in to where we're staying as fit as we possibly can. I'm making a big push with a lot of other organizations that have set forward a standard that we're going to get you back into that military mindset a little bit. We're not going to make you do PT every day, but hey, a little bit of PT a week ain't bad for you.
Yeah, for sure. Talk about the mental side a little bit more on that too, because the physical side, I think, is something that I don't want to say we have it all figured out, but there's like sort of big buckets there that nobody argues about, right? It's like exercise is good for you. Sleep is good for you. And actually, I'd love to get your cut on sleep too, because that's something where I think we've had a big sea change where, the military is kind of like prides itself on no sleep and drink tons of coffee and everything. And we know a lot more now if we were just blind to it before of like, hey, we probably should get a little more sleep. And eating well. So we'll shelf that for a second. But on the mental side, there's kind of two questions I would throw at you. One is outside of the psychedelics, which I think a lot of people see as almost like a magic pill and whatnot.
Yeah, and they got to stop that.
And it's not a magic pill. I mean, in my estimation, my opinion, it can certainly, I think it absolutely has benefits, and we should be going forward with that. But there's a whole bunch of other stuff that we should be doing with that too. And what does that look like inside the VA in terms of just improving that? Everyone hears the 22 veterans a day killing, suicide, that kind of thing. But then on the other side of it, to the active duty, the preventative side of it too. Like, how do we get upstream of that? Because I never learned like how to take care of myself mentally when I was in the military. It was just like, just grind, just go, suck it up, just go, deal with it, that kind of thing.
Yeah. Well, since, you made a great point here, and let me just sort of hit something that this goes back, I'm a chaplain. So, my job is to keep the machine, which is the only machine that matters in the military, and that's the personnel, ready to go at a moment's notice to fulfill their job. That was, I break down, yes, we're there for spiritual component. Yes, we're there for freedom of expression and freedom of establishment and all those kind of things. And that's all perfect in what we do. And I'm as strong in my faith as anybody. But I also understand my job and my role in the spiritual condition of the airmen and soldiers and Marines and sailors that we deal with is, are they ready when it's time to, drop the flag? That's my goal. And that's what I'm there for, is to help them get that along. I don't think we do a good job of admitting that the mind is a weapon system. I think we talk about it. I think we talk about being physically in shape, but think about it. How many, comparatively to this, and I'm not picking on anybody here. This is just the fact of all military branches. How many times do we talk about PFT scores, but not talk about mental health, quiet time?
Yes.
How much time do we talk about how many push-ups and pull-ups we did, but we don't talk about, did you get at least 7 hours of sleep? And outside of war zones, let's just think about this. You can get 7.5 hours of sleep because you're going to get up and go do through the work day, but get your ear in bed. Quit staying out. Quit drinking coffee at 8 o'clock at night. Don't do those kind of things. I get it. And look, I grew up, I got 3 kids. They're all grown now, but I know what burning in. I was working, I was coaching football, going to law school, and trying to put a military career all at the same time. I get it for my kids, but you got to take care of yourself. So back to the concept, the mind is a weapon system. So if the mind is a weapon system, what do we need to do from chaplain perspective, mental health perspective, from a squadron, platoon, battalion, regiment leader? We've got to emphasize the fact that being mentally fit is as proper as being physically fit, and it's not a weakness to focus on getting your mind right, getting that stress level down, learning breathing techniques, learning the things that help you get to where that you can lower the cortisol, you can lower the stress level. Those are huge items that go back to the previous question of preventative. You start lowering those things, you're going to be a better weapon system. And here's the other thing. Let me just share this with all of your listeners out there. I have a daughter who has spina bifida. She is 33 years old. We didn't know she's going to live past 30 when she was born. She's paralyzed from the waist down. Has one of the best attitudes of anybody in life. I wish I had her attitude of life. Okay. Jordan is precious. But when I go out into town and she's in her little chair and she comes with me, people will look at Jordan, see the chair, and feel sorry for Jordan. There will be sympathy for Jordan.
Right.
Now, if I was in that same mall area or same church venue or same meeting room and I stand up, they look at Jordan, who has a physical disability, and feel sympathy. But if I stood up and says, hey, everybody, I'm having a tough day, my mind's not working right, I'm broke, there won't be sympathy. Unfortunately, we repel from that because we don't know how to deal with it, because probably some in that room are having the exact same feelings and they don't want people to express it. Let me tell you right now, I don't care how good a shot you are. I don't care how well you run a marathon. If you're not mentally prepared, you're not completely engaged to being the soldier and the veteran we need you to be. It's okay, as Jelly Roll says, it's okay to not be okay, but you got to help to get fixed. And I think those are the kind of things, mental health wise, that we need to focus on a lot more.
Do you see that actually? I mean, I know it's not your department, but do you see upstream things being done in the DoD, Department of War, moving forward to kind of do some of that preventative stuff to teach people that kind of thing?
I wish I could say completely yes, but I can't. I mean, it's out there, it's discussed. I mean, how many times, for those of us still in, you got to teach resiliency and leadership. And I think sometimes we mask resiliency as, well, you made it through the week and you didn't have a blow up and have to go see the first sergeant. That's not resiliency. Resiliency is how do you manage the internal processes of everything going on and be an active, functioning, completely there person. And so I think it's there. People talk about it. I'm hopeful under Pete, and I respect his leadership a great deal. I think he gets this, as well. But again, we've got to get to that mindset that it's okay to have a battle buddy. It's okay to have a wingman. It's okay to do that. Now that's inactive. I ask this question all the time. I say, since when was it okay to never leave anybody behind in the military? But the minute we get out, we leave those buddies that we haven't seen behind. We don't call them anymore. We don't text them anymore. And yet we're surprised when one of them, unfortunately, has death by suicide. We don't leave anybody behind. If you're a veteran out there and you've been out for 5 years, but yet you still keep in touch, or there's that person on your mind that you know you need to text or you need to call, do it right now. Stop the podcast, hold the podcast, call that person, because I think there's a reason. I'm a man of faith. I believe God lays people on our hearts. And if we didn't leave them behind on the battlefield, you daggum sure can't leave them behind once we get out.
So to that point, since you have to deal with veterans now who have probably never done some of this kind of stuff, and like we talked about, there's treatments that we're trying to get in the pipeline, psychedelics, whatever else, that is going to be a ways off. So what else is being done on the mental health front specifically? Like how else could that get better within the VA, within the current confines of what you have to work with?
Well, I think, we're expanding a lot of our telehealth, even for folks who don't want to come in. They can call, they can, use telehealth counseling appointments. We have our crisis lines, if they ever want to talk, 988, just press 1. There's somebody always there to talk. And it's, a free service. They can call 1-800-MY-VA-411. That's another aspect that people can talk. But I think the other part in the VA is just expanding out how we treat our veterans. But there's one plug that I want to give that most never get to hear, and that's called the vet centers. They're coordinated with our hospitals, but they're not part of our hospitals. You'll have them in every big city. You'll have them in every area where we have a hospital. It's called vet centers. Vet centers came out of the Vietnam War era veterans who felt like that they, were being left behind and all. And so they're separate. They can treat even people who are not eligible for VA healthcare or VA benefits. A veteran, if you served at all, can come in there, and there is counseling, group counseling, family counseling, which it's harder for us to offer in the VA facility itself. So I'm pushing our vet centers in a big, big way, because I just see them as our tip of the spear in many of our places to get people into the system, even if maybe they don't want to register for VA benefits right now, but they're willing to at least go talk to some others and get some help that they need.
Going back to the this is going to be a little bit self-serving in terms of the Navy SEAL Foundation, but I'm just curious, as you look at, there's so many nonprofits out there that support military veterans. You look across that landscape. How do you view that interacting with the VA? Is there a better way to do that? Is there a way that like nonprofits can work more complementary with the VA, right? Because sometimes it's things like I was saying before, where there might be something that the VA just can't do currently, where a nonprofit can kind of maybe step in and provide that gap a little bit. But I guess overall, it's like, how do we potentially work better together to kind of like cover everything, Yeah.
I have opened up the VA to work with anybody willing to help us help veterans. And that's not always been the case here. I've talked to a lot of nonprofits, a lot of others that are dealing. A lot of people want to help. Sometimes they don't have the resources. They have a good idea, but they're not fully funded, and they're funded, and they kind of want the VA to be their funding source. That's just not our job to do that in a way. We're there to help, and to not deter people from getting some of those help. But also, I think our nonprofit NGO group VSOs, I think a lot of the groups have found niches, and I think by them working with us to get people through programs where they're willing to go through programs, I think is very important. One of the things I would ask for all of our nonprofits and NGOs who do, retreats, who do, programs, all this kind of stuff, is ask a simple question for us, because there's stuff that I can do that y'all can't. And that's like healthcare. That's like wraparound services. That's like drugs and medications. All this kind of stuff, that if they're sick, they have diabetes, they have heart issues, those kind of things, is if they're coming to some of your programs, ask them in all honesty, are they enrolled in the VA? Are they a part of the system? even if they are not, even if they maybe have private insurance or they're wanting to do something else, at least being a part of the system, because at some point in time that may go away and they need health care. They need the benefits that they've earned. Nobody, by taking advantage of a benefit earned, is keeping another veteran from getting a benefit. Is that clear? I mean, I think I care so many of our veterans who say, I didn't take mine. I had some folks who were going through treatments in a nonprofit that we do a lot of work with. And I asked them, I said, well, were you involved in the VA? No, I wasn't that bad. That's for somebody else. Hear me clearly, veteran. Just because you take the VA benefit that you earn does not take it out of somebody else. Now, if you don't need it, God bless you. We love you. You're still a veteran. Go do great things, but also don't go without. And this leads to my sort of final point. This is why I'm wanting to make the transition out of active duty into the VA seamless, especially for those who had issues while they were in active duty. We're working a program out now to hopefully within 4 or 5 weeks of discharge, we have a warm handoff between Department of Defense doctors and our doctors, so that there's nobody who takes a step out of either, that they're even 1 minute left without a doctor, without left anybody that they have. Because I've had so many of them who've left and they felt abandoned and they didn't know what to do, and then they spiraled from there. So we're working on that.
Is that a program that's internal to the VA, or is that something that
it's something we're having to work on with DOD right now, and it's not in place right now. It's just it's sort of given lip service to, but it's not in the way it needs to be. I mean, some areas are better than others. We talked about not all of the same. Some areas do it better than others, but it's something we need to standardize on, especially with those who have TBI, traumatic brain injury, CTE, all these kind of, concussion-based or toxic exposure issues that they are already getting treated for, especially in the mental health area.
Yeah. I guess the question was asking is that a program where the practitioners do it, or the veteran does it, or a little bit of
No,
both?
it's part of your out. What we're wanting it to be is part of your out processing. Got it.
Just on I didn't fully ask this question before, but on the toxic exposure thing, what are the best treatments inside the VA? Like, what is that? What's the road there? What do you do about that?
I wish I could answer that in a direct way. I can't, because toxic exposure, it affects you in so many different ways depending on your level of exposure. Look, I'm a burn pit guy from Balad. I mean, sure. I woke up every morning, it looked like fog and it was just burn. I mean, so that affects, how is that affecting my lung capacity now? I really couldn't tell you at this second. I know that I don't run like I used to. And that's probably because I'm almost 60 years old, but that's a whole different issue too. But, my sinuses haven't been the same. I mean, there's a lot of things. So it really depends on what how you present with your issues as far as how you'll treat it, from cancers to, chronic illnesses and things like that.
Okay. One of the things I haven't brought up, which is something that I think there's people sort of pay attention to, but don't know what to do about it, and it affects veterans, is homelessness. And we got some questions about that. What can be done about that? Because it is one of these problems that everyone sort of doesn't like, but doesn't have a great solution for either. And
no,
it definitely affects veterans a lot.
Yeah, you really don't. And look, veterans homelessness over the last 20 years has come down at a far faster rate than the average Americans. In fact, the average American homelessness population has increased while the veterans have decreased, because there's a lot of emphasis on it. Look, we work with, there's a lot of causes around that. So you can't, it's not just, one different issue. I mean, you've got some former veterans who, frankly, I could put them in a 10-bedroom house today and they won't stay. Okay. It's because of life and because of everything else. So we're trying to make sure that they have the proper housing as they need it, temporary housing. We're working with our hospitals to go out and give veterans in the community, but also dealing with those who have sort of homelessness has been brought on by life circumstances that have happened since they got out, whether it be financial issues, drug issues, mental health issues, relational issues, however you want to put it. We're trying to get them into temporary and permanent living homes with what's called a HUD-VASH program, which gives rental assistance, those kind of things, so that we can then wrap the services around them to get them back to being productive citizens and not sort of teetering on this edge of homelessness and destruction all the time.
As you look to kind of the future of the VA, if you could sort of wave a magic wand or whatever, what would it look like 5 years from now, 10 years from now, past past when you're in the seat,
Yeah.
what would have been like kind of the major things that you could kind of hang your head on and say, this is something that we made for the better here, and it's really improving the lives of veterans moving forward?
I think if we continue the process, no matter who sits in his seat, of putting a veteran first and making sure that the organization exists for the veteran, I think that will continue on. I think our reorganization of how we get answers to the field and how we do our medical treatments and how we take care of our employees is going to be a huge asset. How we actually use technology and disability benefits to faster process those. One of the things that a lot of veterans complain about is the C&P exams. You know, they apply for disability and they said, okay, well, let's send you to a doctor to see if that, you know, knee injury was really a service related injury.
Right.
And
Yeah.
well, those are just, you know, some of that is just, we spend a lot of money, literally billions of dollars doing that when most of it was already recorded in the file to start with. So my question, you know, my question I pose to our team is, why can't we use technology to help roll those out so that we can, you know, get them into the system quicker, because we already know they're going to be approved. Let's just get them into the system and then work with them instead of spending $2 to $3 billion a year on these outside exams. So this is all kinds of stuff as we move forward. My best thing though is I want there to be a culture of excellence at the VA that says quality is our number one concern, and that treating veterans with the best possible care that they can get, whether it be in our hospitals, our benefits, or our cemeteries, is the ultimate gift that this country gives back to a veteran.
I know I'm kind of bouncing back a little bit here, but just a couple things on the psychedelic thing as I kind of thought more through it. Is that something where, do you see that as a phased rollout? Would that be something where it's like one specific psychedelic gets kind of approved and into the system? Or is it like, okay, boom, boom, maybe not Ibogaine yet, but like, boom, all the rest of them are sort of good to go at this point?
Yeah, that's out of our hands a little bit. I
Okay.
think we're rolling it forward as best we can, one of the limitations and money we have. Again, the one thing that clinical trials allow you to do, if they're help sponsored by, you know, some of the, you know, companies or drug pharmaceuticals or whoever that helps get us the drugs, you know, again, you haven't worked in the cost of that yet. And that's always an issue. So I think it's going to be you know, we'll see how it rolls. I think I would be a little more concerned if all of a sudden it was just sort of the Wild West, that you could sort of do it anywhere. But, you know, look, I'm very supportive of this administration. Bobby Kennedy is a good friend. Bobby is committed, I know, with his folks in FDA to do what we can as quickly as we can. You'll always have my promise, though, that with veterans, you may not like my speed, but you'll always like the fact that I'm going to put you first and make sure that we're not going to do something that I have to go explain to your family why it didn't work.
Yeah. I'm just curious, actually, is that something like I had a complete sea change on my attitude towards psychedelics? I grew up thinking these are the most dangerous things on the planet. Like, they make you crazy. People only take them just to get high, and that's it. And my attitude is so different now. Was that your experience too?
Yeah, a little bit. It was.
Okay.
I mean, and again, how does this help you? And then I've sat down with our doctors. I've sat down with our psychiatrists. I've sat down with those who've walked it. I've watched videos of how, you know, the treatments of how this goes. And as I had one doctor who came into it very skeptically, said this is not going to work. They were, you know, sort of old school, classically trained. Said this ain't gonna work. And they said, now this is our opener, because what they said was, for whatever reason, however it does it, it opened the mind to the right page to deal with the issue that needed to be dealt with. And that just blew me away.
Yeah.
And it's as somebody who's clinically trained and all of this other stuff, that that's what they say about the way psychedelics work, that it tends to go straight to the heart of the issue. And actually, I've had them talk about that a person who had multiple issues, that it went to the very first issue first. And then on the second round of treatments, a few weeks later, it opened up the door that would have never opened up had the first one never been dealt with.
Yeah. Right.
It's pretty amazing.
Yeah. No, I think my experience is that the experience can be completely different for
Oh
different
yeah, and
people,
you got some, it just doesn't work. I mean, I'm going to be brutally honest. It just doesn't work for some.
Yep. Yeah. And I think the other thing that's tricky about psychedelics is it's so experiential, where other drugs, it's like, okay, we give you 5 milligrams of this and it treats this and it does this, and it's basically going to have this effect on most people. Whereas you could give the exact same dosage to two people and they have wildly different experiences based on that. Right. And that's part of the trick of the whole thing. If you were a betting man, I'm not holding you to this, but how is it, you know, the day that a veteran could go to a VA clinic and receive a psychedelic treatment of some sort, is that 5 years from now, 10 years from now? Like, roughly, where do you think that will happen?
Yes.
Got it. Okay.
I can't say that right now,
Yeah, fair
simply
enough.
because of the limitations outside of clinicals. I do know that there's a lot of discussion on clearing it up in the in the civilian sector as well. So that may end up speeding it along a little bit. There's just a lot of questions that have to be answered before you get there.
Sure. Yeah.
As we go, and not that I'm opposed, and for somebody to say, see, the VA secretary don't want it. No, you're not listening right. I didn't say that. I just said there's a lot of issues as you go because, let's just put it this way. If it gets out in the public and, the way it is, and it's $15,000 per counseling session and insurance doesn't pay for it,
of course,
you got a problem.
Yeah. Yeah. Outside of psychedelics, maybe it's some of the other stuff we've talked about, but what other treatments do you find the most promising, like that you're the most excited about that could have an effect for people?
Yeah, I think there's a lot of things. Visual stimulation is out there, which there's a lot of discussion. Virtual reality. There's a lot.
Okay.
When you get the non-drug related stuff with the magnetic pulse and reconnaissance, I think are really showing some very interesting signs. Hyperbaric. There's a lot of things out there that are showing, signs. And I think it just goes back to the fact that we're in a situation dealing with stuff that we can't put our finger completely on that says there's a lot of things that work for different people. And
Right.
so I think we just have to be open to those possibilities, that they're out there. What I do think that we have to get away from some is this old line thinking that the way we've always done it and is sitting down in a counseling room and talking about the stuff over is probably not our best outlet for that.
Yeah. Yeah.
It does work for some, don't get me wrong.
Yeah, of
But
course.
it's like everything else. It's you can't say it's the only thing.
Yeah, of course. Of course. Does the VA do EMDR at this point? Do you know what I'm talking about?
It's the electronic.
It's the eye movement
Yeah.
desensitization.
Oh yeah. We do
Yeah.
that. Yeah,
Okay.
we do.
Yeah.
Look, there's so much stuff that we have going on that deal with this, and that we deal with on a day-to-day rehabilitative basis, on balance and stuff like that. That you can start picking up signs of that are neurological signs of stress or de-stress that we're working on in almost all of our hospitals. Those are things that we can work on without, have no drug interaction or related to.
Yeah. I know we're coming up on time here. So just kind of last few things here. What else is the VA working on that people don't know about? Or what are the other kind of misconceptions out there from people that you are trying to get the message out about, or something we haven't touched on that you want people to know about?
I think the last thing, to wrap this up is just simply say the VA is not a subpar medical facility. We're not, our doctors aren't here because they couldn't get a job somewhere else. They're good doctors. They're great nurses. They're people who care. And really, in some ways, they're there taking less money and less prestige than others because they want to help veterans. And I think that's something that needs to be figured into the system, that you have so many of them veterans themselves who just simply want to help. And that, as we said earlier, the perception is that, it's sort of outdated medicine. And the reality is, I would put up some of our stuff, especially in polytrauma and a lot of the other stuff. I'd put us up against Mayo Clinic and, a lot of the others, especially when it comes to the research inside and how we do cutting edge. So I think that's the biggest thing I could say in sort of summing up.
Yeah. I will say I love my VA doc. He's awesome. He's probably my favorite doc I've ever had, because he's very progressive. He's cool. Like, I dig him.
We have some good folks.
Yeah. All right. Well, Secretary, thank you so much for coming on, for spending the time with me. I know, kind of like you said, I know that I can only imagine that how kind of thankless this kind of job and the amount of heat you sometimes get, for doing it, but it's so important, and greatly appreciate the work you're doing and everything you said on this. I think it really provides me a lot of hope. I think it kind of cleared up even some of my misconceptions about the VA. So I really appreciate it. Thank you.
Well, I appreciate it. Thanks for having me on. And before anybody goes to the comments and says that ain't my experience and he's just full, look, guys, we're working this through. We're going to get there. So just hang on. And if you got issues, let us know. We're going to fix the issues.
To that point, if people have legitimate feedback where it's not just complaining in the comments, what is the best path for that for them?
Well, I think at every one of our hospitals, there's patient advocates. There's others that they can go to. They can call the 1-800-MY-VA-411. They can talk to people there as they go forward. And also, we do respond to the comments on my social media and others as best we can. So we're doing everything we can to keep people informed.
Thanks for listening to On the X, the official podcast of the Navy SEAL Foundation and an Ironclad original series. Learn more at NavySealFoundation.org or text On the X to 60104. Please like, share, and subscribe. See you next time.